Now, I think that when we approach screening, we need to start getting smarter about it. And what I mean by that is recognizing that there's a general recommendation of starting breast cancer screening at approximately age 40, doing it every 1 to 2 years, but trying to figure out what my risk is, what the individual woman's risk of developing breast cancer is. And there are screening tools or risk calculators that can really help out with that. So knowing some of those modifiable and non-modifiable risk factors and how it pertains to the woman or the specific patient at risk is really helpful in sort of deciding or designing what the optimal screening program should be.
Today, I have a very special guest, oncologist Dr. Zia Poonja, who practices in Victoria, British Columbia, Canada. We will be discussing some of the important advances in breast cancer prevention, screening, and treatment. This will definitely be a very informative and engaging interview, and I think you will really enjoy the information that Dr. Poonja has to share with us.
Dr. Zia Poonja completed his undergraduate and medical training at the University of Saskatchewan. He received his residency in internal medicine from the University of Alberta and a medical oncology fellowship from the University of British Columbia. He has been practicing oncology at BC Cancer, Vancouver Island Center for the past 8 years. He is actively involved in clinical trials, research, and medical education. Dr. Poonja's passion lies in preventing diseases before they arise, and he founded Healthspan in 2021 to offer patients the latest insights in the preventative medicine landscape.
Dr. Poonja, thank you so much for joining me today.
You're welcome. It's a pleasure.
For those of the audience who don't know you, could you tell us a little bit about yourself and how you ended up working in this area of oncology?
Sure. So I am a medical oncologist. I have been practicing breast cancer for the past 8 years with the BC Cancer in Victoria. And I treat breast cancer, lung cancer, and oral cancers. I have a really keen research interest in the prevention world. And that started about 4 to 5 years ago. And it's been a combination of factors that really got me motivated to understand what people's risks are when developing cancer, but not only cancer alone, also any disease. The questions that come along with respect to health optimization have really been something that has been motivating me from a research factor for the past few years.
Yeah, and we are going to talk about breast cancer specifically. However, I noticed that you also have an initiative called Healthspan. And I think this goes back to what you were talking about as far as prevention goes. And I was looking on your website, and I think we might have you back for a talk just to talk about Healthspan. But could you briefly just kind of give us an intro on what Healthspan is and why you've developed this?
Absolutely. So Healthspan is a passion project of mine that is really born out of an understanding that our current healthcare system is far too reactive. And there needs to be an option for patients who would like to be more proactive. And proactive, but in an evidence-based fashion, and being able to get testing done immediately on a screening level to help one understand what their risks are. So from a genetic standpoint with respect to cancers, but also just from a blood work standpoint in terms of understanding patients' inflammatory markers, their advanced cardiolipid markers, and trying to get that information in a one-stop shop so that they can then make decisions, because there's a lot of new advances that have come across over the last 5 to 10 years, but we want to make that increase the equity or the uptake, the ability of people to access that in our health system. And I find that that's a struggle when our health system is only really concerned when we develop the cancer or when we have a disease, but not a lot is being time spent sitting down and actually having that discussion of what we can do to prevent it in the first place.
I think there's a real lack of prevention and of, like you said, proactive measures in the healthcare system. Do you feel like you're a bit of an anomaly?
I would admit, it's not common,
Yeah.
but it's a huge passion. My father had colon cancer in his 50s, and that was probably the impetus right there to recognize, what could be done better. And recognizing that he had a genetic mutation that predisposed him to a higher risk of developing that colon cancer, and recognizing that in the research there are a lot of things that people can do to reduce their risk, and making that available for everyone is something I really wanted to be part of.
Yeah, it's excellent. And we might have you back just to talk specifically about Healthspan, because just had a moment to jump on the website, and it's really, really fascinating. And I think it's definitely something that our healthcare system and our communities really need, is to be more proactive. Dr. Poonja, I wanted to kind of go to the topic of breast cancer, because I know this is one of your specialties. So many of us know someone who has been touched by breast cancer, right? And we know that the BC Cancer Association is just excellent, but everyone wants to know how to prevent this terrible disease. And so, in your practice and from the literature, have you seen, we'd like to know, are breast cancer rates increasing right now, and is screening and our diagnostics improving?
So for the most part, if we think of incidence rates of breast cancer among females, there was a very dramatic increase in incidence in the mid-1990s. And that was really related to more widespread adoption of mammographic screening. Mm-hmm. And over the last 2 decades, we've really seen a plateau, or maybe a mild oscillation, but not a large dramatic increase in incidence. We do know, though, that breast cancer will affect 1 in 8 women by the age of 85. And it is, for women, the leading cause of cancer-related disease burden. With respect to diagnostics, so the quality of mammography, which is the main screening tool, has dramatically improved. So if we look at studies in the 60s, 70s, 80s, and 90s, and actually look at the quality of those mammograms compared to the digital mammograms we're seeing now, there's a dramatic difference there. And certainly in the now era, we would say that mammography is our best tool, offering survival advantages or mortality reductions of approximately 40%.
Wow, 40%. That's quite significant. So that mammography is a kind of, would you say, the backbone of breast cancer detection and screening?
Yeah, it is the backbone. It's the best tool that we have for screening a large patient population. It doesn't mean that it's perfect, and there are other tools that help us when we find abnormalities, or if there is a concern in the breast, like ultrasound and MRI. But it's the backbone and best screening test that we have.
Mm-hmm. And we know that, I think the general public understands now that if you have a close relative, like a mother or grandmother or something like that has had breast cancer, then your chance of having breast cancer is probably increased, right? And so we know that there are those are things that you cannot change, right? So we know that there are modifiable risk factors, and then there are non-modifiable risk factors, because we don't choose what family we're born into. We don't choose our genetics, right? So could you go over a few of those risk factors for us, both the modifiable and non-modifiable?
Sure. So if we start with the non-modifiable risk factors, the main one there that would really increase one's risk of developing a breast cancer is a genetic mutation. And the 2 most common ones that we know of are BRCA1 and BRCA2. And those would, increase one's risk by about 15 times compared to the average population. Another non-modifiable risk factor is someone's personal family history. So if you have a personal family history of breast cancer, then that increases your risk. So what I mean by that is a first degree relative, like a mother or a sister, being diagnosed with breast cancer by the age of 50. Well, that increases that person's risk of developing a breast cancer. If someone has had breast cancer, then that also increases their risk of developing another breast cancer. If they've had a biopsy showing a non-cancerous pathology, like a DCIS, something like a precancerous lesion, or a LCIS, which is those are both precancerous lesions. We know that in those women, they are also at increased risk of developing the real deal breast cancer.
Okay. And are there any environmental factors or diet, or is there any evidence for any of that?
Yeah. So in terms of the modifiable factors, we have a host of them. And the main are lifestyle factors. So we know obesity carries an increased risk of breast cancer increases your risk by approximately 30%, and alcohol use as well. And it also increases the risk of breast cancer.
Okay, so there are some things that we can do proactively as far as lifestyle goes, and like you said, the modifiable risk factors that can help to reduce our risk. So that's great. What is the current recommendation for mammograms in Canada? It seems to be changing every few years. I think some people might be confused by this. Could you clarify this for us?
Absolutely. So it's right for people to be confused because different provincial screening programs have chosen different targets. So numbers that are usually thrown around is starting at age 40, or there's some controversy and says, well, let's start at age 50. Mm-hmm. I think based on the best available current evidence, screening mammography should be started at the age of 40 to about the age of 75, because that's the age range that we start seeing an increased risk. And the second question that's usually a bit more controversial is, well, how often should I be getting a screening mammogram?
Right.
And the answer to that is also a challenging one, because screening recommendations or screening guidelines are confusing that matter. And I would say in general, every 1 to 2 years would be the appropriate time for a screening mammogram. Now, I think that when we approach screening, we need to start getting smarter about it. And what I mean by that is recognizing that there's a general recommendation of starting breast cancer screening at approximately age 40, doing it every 1 to 2 years, but trying to figure out what my risk is, what the individual woman's risk of developing breast cancer is. And there are screening tools or risk calculators that can really help out with that. So knowing some of those modifiable and non-modifiable risk factors and how it pertains to the woman or the specific patient at risk is really helpful in sort of deciding or designing what the optimal screening program should be.
Yeah, that's interesting. When I was studying for this interview, I actually went onto a website from the NIH, and there's actually a screening tool on there where you put in some information. One of the things I couldn't answer because it had to do with the BRCA1 versus BRCA2 results, right? But it came up with a percentage of risk for me. And I thought, well, you know what? If someone's concerned, they could even do this themselves, take this to their GP or something and just say, listen, maybe we should screen more earlier or not, or something like that. So I mean, even people can even do this at home, or I just thought it was a really interesting tool, and these are accessible online even sometimes.
Yes.
Mm-hmm. So we know that there are different types of breast cancer and different classifications. And so can you give us a little bit of an overview of these types of cancer and how breast cancer is classified?
Sure. So first of all, breast cancer is a broad group of cancers that could arise from the breast. There are some there's different cells in the breast. The cells that are causing the traditional breast cancers, or the majority of the breast cancers that we think of, are coming from the milk ducts. So these are cells that line the milk ducts, and if they develop, if a mutation occurs in them, then they can either become a precancerous lesion, and we know those to be either ductal carcinoma in situ or lobular carcinoma in situ, or it grows into a true cancer, something we call an invasive ductal carcinoma or a invasive lobular carcinoma. Pre-invasive cancers represent, approximately a quarter, and invasive cancers are by far the majority, representing about 75% when we look at all the, histologies that a pathologist would come across. When we think about breast cancers more specifically, when we're looking at those invasive cancers, we try and subtype them. And there's different ways of doing that. The most meaningful way for us is subtyping them based on their receptors, or and the reason why we do that is because these are targets for our treatment. So we have triple negative cancers, we have HER2 positive cancers, and then we have ER positive cancers. ER positive cancers being the ones that harbor or carry or overexpress the estrogen receptor. HER2 cancers harbor and overexpress the HER2 receptor. And then triple negative cancers don't have the ER or the HER2, and these don't have a specific target for us in terms of treatment. And that's why we sort of classify those into the three broad categories. There is a way of genetically providing a molecular subtype, but that's really done in a more research setting. And it's helpful because it provides some information on prognosis. So in general, we think of ER positive cancers as having a more favorable diagnosis, HER2 cancers being a bit more aggressive, but with the advent of new treatments that we have, having a fairly good prognosis, and then triple negative cancers being a bit more of a challenge to treat, and in comparison to a genetic subtype or an ER positive luminal A. So luminal A would be the genetic subtype of cancer, having, if we were to compare a triple negative to a luminal A ER positive, we would say that the triple negative would have a poorer prognosis.
Okay, that's excellent. Thank you for explaining that. That's quite impressive, because that must not have been easy to explain. So thank you. So these BRCA1, BRCA2 gene mutations, we mentioned this before. So can you tell us a little bit about what this means? Is there a blood test for this? Do we test proactively for this? Is there any use to doing that for people?
So this is another controversy. And let's just start by explaining what are BRCA1 and BRCA2 gene mutations. So these are mutations in someone's genetics that dramatically predispose them to developing a breast cancer. So we know that 50 to 70% of women with a BRCA1 mutation and about 45 to 70% of those with a BRCA2 mutation will develop breast cancer by the age of 80. And that's because they carry this genetic signature, which prevents repair of a gene that's responsible for repairing a certain type of DNA damage is not present in them. So the question then becomes, well, should everyone be screened for BRCA1 and 2 mutations? And that's where a bit of controversy exists, because on one hand, the mutation isn't that common. And you can sort of spot it by seeing those who have a lot of family history of breast cancers. So currently, provincial plans will cover genetic testing for patients who they deem to be at high risk. So those with a strong family of breast cancers, those with a strong family of breast cancers occurring at a young age would be eligible for public free testing. The great thing about genetic testing is the prices have come down significantly, and it's available in a direct-to-consumer way now that anyone can really access. So it is possible for people to pay for genetic testing to figure out if they have these mutations.
Mm-hmm. And I know, yeah, it is a little bit controversial. Everyone has their opinions about it, right? But yeah, people can do it. They are available.
And on the opinion piece, and maybe this is my opinion, but my strong sense is that people need to be educated. And if they understand what their risk is, or they even understand the test, then they can make up their own decision. And I think that really sort of speaks to, wanting everyone to be able to have as much access as possible. Yeah,
absolutely. And are there any other blood tests or anything like that that can detect breast cancer? So I know you were speaking specifically of genetics, but as far as blood tests that can detect whether you have cancer or different markers that you would look for, does anything like that exist at the moment?
There are tests being developed, and one that is commercially available for looking at circulating tumor DNA. Mm-hmm. So what is that? So we have DNA fragments that circulate in our blood, and we can spin that out, and we call that cell-free DNA. And then within cell-free DNA, we can look for tumor DNA. So we know a certain tumor signature, and we can try and look for that in patients. And that's really the where our hope is that is where surveillance is going. And there are tests that are being developed, and we're working on the sensitivity and specificity to see how powerful or precise these tests can be in detecting someone who may have a cancer using a blood-based test. There is a company based out of Calgary which has a commercially available test that patients can purchase to look for a breast cancer. And I would say that these tests right now don't substitute mammography because the evidence isn't as robust, but they certainly are an option. And as we develop our knowledge and we get more information about the sensitivity and specificity of these tests, it's going to be a real game changer for us.
Oh, that's excellent. That's great to know. I did not know that. What about immunotherapy, Dr. Poonja? Is that an option? Do we use that very much in breast cancer? I'm hearing that that's being used more and more in different types of cancer. But what about breast cancer? Is that ever used or commonly used?
Yeah, so we are starting to use it more. Immunotherapy is used a lot in my lung cancer patient population.
Oh, okay.
And we are starting to use it now in the breast cancer population as the trials are emerging and maturing, that's showing a benefit in certain subpopulations. So we know in the triple negative patient population, so those that don't express any of those receptors, there's been in certain settings, so depending on stage and where the patient's at, the option of using immunotherapy. And in the clinical trial setting, we're also evaluating these questions in other patient populations, like combining it with HER2 treatments to see if immunotherapy can offer a better advantage. So it's there, but not as widespread as it would be in for example, lung cancer.
And I guess for those who don't know what immunotherapy is, could you just kind of give us a little bit of an explanation of what this type of therapy is?
Sure. So on the most simplistic level, immunotherapy is trying to use someone's own immune system to target a tumor. And how we're doing that in the clinic is by giving patients antibodies. And these antibodies either stimulate the immune system or take away. It's thought that cancers hide or evade the immune system by using certain pathways to make them to basically be able to hide from the immune system. So we're giving these patients an antibody to override that, to sort of lift the rug off the cancer, so that the immune system can see it and can start using our own mechanisms of cell destruction, using our B cells and our T cells to try and eat that cancer up.
That's great. So it sounds like there are quite a few different ways that we can screen for breast cancer and even treat breast cancer, and immunotherapy. That sounds really positive that that's being used. Just another tool for us, right? There is a modifiable risk factor that I wanted to kind of touch on. What do you think, or what is the literature saying about the use of alcohol and the risk of breast cancer? I know there's been a lot of information about alcohol and different types of cancer, but when we speak specifically about breast cancer, could you speak to that for us?
Absolutely. So alcohol is a class 1 carcinogen from the International Agency on Research on Cancer. We know that. We know that it causes cancer. And we also know from good data. So we have the Nurses' Health Study, we have the Million Women Study, all showing that consuming alcohol, in the Nurses' Study, it was 3 to 6 glasses a week, resulted in approximately 15% increased risk of developing breast cancer. But the way I like to sort of take it back is understanding the mechanism, because I think if we understand why and how alcohol is causing the damage, then it can perhaps better inform us on what we should do about it. Mm-hmm. So alcohol, ethanol alcohol, when we consume its ability to cross cells is very easy. So it's not like fat, like that would float or that would need to stay within a particle. Alcohol can permeate in and out of any cell very easily. So when one consumes alcohol, that alcohol goes basically everywhere. It floats around the body. And we know ethanol alcohol itself, in breast cancer cells, or in breast cancer, or in normal breast tissue, stimulates estrogen pathways. So that's one mechanism where we can see that ethanol itself is causing setting the environment up for someone's increased proliferation or growth. Ethanol also needs to be broken down. So it's a toxin, and our body does a good job of breaking it down. We use alcohol dehydrogenase, and it converts it to acetaldehyde. But acetaldehyde, when it's circulating in the body, and more specifically when it's in breast tissue, causes DNA damage. So it makes DNA unstable. And when you have unstable DNA, there's a greater probability or chance that you can have a mutation occur. And sometimes that mutation can be picked up by the body's own systems, and sometimes it's not. And if it's not, then you develop a cancer. And we also know that alcohol suppresses the immune system. So there's a few mechanisms from the basic science that really help frame our understanding of why we would consider alcohol a class 1 carcinogen. And the common question I get is, well, now what should I do? And I would say, that's an individual decision. My recommendation is usually the safest level of intake is none. But that's also a personal decision. But I think that personal decision is more easy to make once one understands what the risk is and what the damage being done and how it's causing damage.
Yeah, I've never heard it explained like that. And I have read the articles, especially the more recent ones that have come out, about how alcohol is quite a potent carcinogen, but no one's explained it like that. So thank you very much for giving us some more understanding on that. That's excellent. There's something known as primary prevention of breast cancer that I was reading about. And this is something that I'd just like you to maybe tell us about, and what what women or what groups of women might be more, might benefit more from what's called primary prevention?
With primary prevention, it's making reference to risk-reducing medications. So these are women who don't have breast cancer, but have a very high risk of developing breast cancer. And those are, in general, women with a BRCA1 or BRCA2 mutation. So those at a very high risk. So we're talking, that 60 to 70% lifetime risk of developing a breast cancer. And for them, there are, primary prevention medications that can use. There are options for undergoing a risk-reducing mastectomy or removal of both of their breasts. But some patients, may not want to undergo a risk-reducing mastectomy. And those that are at increased risk, but not wanting to go for surgery, this may be an appropriate option for them. And there's really three medications that have been studied really well. We have tamoxifen, raloxifene, and exemestane. These are drugs that we use in the cancer clinic for patients who have had breast cancer or who have breast cancer, but it can also be used to prevent breast cancer in the first place in these high-risk women based on a few trials that showed, fairly convincing reductions in the risk of developing breast cancer. There was no mortality benefit. So what that means is, patients didn't live longer or didn't have a survival advantage of taking these risk-reducing medications, but nonetheless, it did reduce the risk of them developing a breast cancer. So it's really is something that can be considered, but it really requires a discussion and first establishing what someone's risk is.
I have a few questions from our viewers, Dr. Poonja. Is it okay if I ask you a few questions? More
Sure.
questions? Someone asked, what are the top signs or symptoms of breast cancer? How is breast cancer usually detected by the public?
So most people have it detected through mammography. So they're undergoing screening mammography programs, and those mammograms come back with an abnormality, and those get followed up with an ultrasound and a biopsy, and that confirms their diagnosis. Others have discharge from the breast or bloody discharge from their nipple. That's can be a sign that there's a cancer in the breast. Some have a painful or a painless lump, so it doesn't necessarily have to be painful. It can be painless, where they feel a mass on self-exam, so they're in the shower, or they're able to palpate a mass in their breast, something that wasn't there before, and then they present to their doctor and get imaging done or in a biopsy that confirms that they have cancer. So a host of sort of pathways of how people are being diagnosed.
And is there a link between breast cancer and ovarian cancer?
So the main link between the two is really through the hereditary syndrome of BRCA1 and BRCA2 mutations. But in general, we think of them as two independent cancers. So if you have a breast cancer, it's independent of having an ovarian cancer, unless you have a hereditary cancer syndrome like a BRCA1 or BRCA2 mutation that actually predisposes you to both breast and ovarian cancer. Okay.
And what are your thoughts on post-menopausal hormone replacement therapy? I know this is a bit controversial. What are your thoughts on this?
So this is definitely a controversy, and an unfortunate controversy, because I think that the studies that have been done in this area have really complicated the landscape. What we do know is that when we're thinking about hormone replacement therapy, so this is hormones that would be given to women in the post-menopausal setting to help with symptoms of menopause. We know that giving estrogen alone is a concern, because if you're giving estrogen alone, you're increasing the risk of breast cancer. And the Women's Health Initiative at least was able to shed some light on that. The question with respect to, can this be overridden if we're giving estrogen and progesterone, is a different question. And I think there is some controversy there. In general, what I would say is there really needs to be a discussion with respect to someone's risk. And if someone has a high risk of developing breast cancer, then I would say stay away from hormone replacement therapy. And I would say that we know that there are studies. The reason why I say that is because we know that there are some studies linking HRT with, except vaginal estrogens. So there are no studies for vaginal estrogens. But there are studies for HRT with increased risk of breast cancer. The question, but there is some controversy there.
Yeah, I've seen a lot of varied opinions on this, but I think yours sounds quite balanced, right? But it is something that I guess we still don't have a consensus on at this point. Yeah,
I mean, I think it's a great question that we could sort of answer in a whole separate talk. And it's, I think there is a safe way to be using HRT, but I think it really, the simple way without getting too much in the weeds is really understanding someone's risk. And if someone has a very high risk of breast cancer, then it would be prudent to stay away from HRT.
Okay, we'll leave it at that. And someone asked, what about soy? So I know that soy has some similarities with estrogen. They asked about is there a correlation between consumption of soy and breast cancer?
So this wouldn't be my area of expertise, but I do get asked the question a lot. And to my knowledge, the phytoestrogens that someone would be concerned about when they would be consuming plant sources like soy aren't really a concern from an evidence standpoint.
Well, that's the last of my viewer questions. But I'd like to kind of ask you, from your practice, from what you see day to day, it can't be an easy job to have, Dr. Poonja, just to, be seeing women who sometimes come in even with advanced cancer, maybe from lack of screening. What would be your message, I guess, to the audience on how to be more proactive, and what do you think are the things that women can do and should be doing more of? I think we're in a healthcare system where you really need to, like you said, be educated and also know how to kind of advocate for your own health. So what would your message, I guess, be to the women who are watching today?
So I think there are definitely items on the modifiable risk factors that I would consider, things that everyone can do. And, the biggest things that we have there are avoiding alcohol and physical activity. So we know that physical activity or physical inactivity, independent of obesity, increases the risk of breast cancer, and is something that is someone can do and helps along multiple fronts. So not just reduces your risk of breast cancer, but a lot of other diseases that come along with aging as well can be substantially reduced by increasing one's physical activity. I think when navigating the field of breast cancer for women, truly trying to explore what their risk is. And that can be done by attending screening mammograms and using the information from screening mammograms to really formulate a good plan on when the next mammogram should be, and the frequency of mammograms based on one's individual risk, based on their family history, and also what's coming on that mammogram. So we didn't touch on breast density, but
yes.
We know that breast density is another factor. So another independent factor that increases one's risk of developing breast cancer. So we know that dense breasts have a higher risk of breast cancer. And they're more difficult to screen because of the density, of the collagen density. It's harder to see tumors there. But we still know that mammograms are helpful. So it doesn't mean we shouldn't be using mammograms. So there are, I think it's hard to summarize sort of everything that one can do, but in general, I think really low-hanging fruit is, looking at those modifiable risk factors and seeing, what can I do? And the biggest ones there are really with the alcohol and physical activity, maintaining a healthy weight. And then really exploring one's own risk by looking at, their mammographic density, looking at their ethnicity. So we know there's, ethnicity also plays a role in terms of Hispanics or Asians presenting at an earlier age distribution than non-Hispanics and non-Asians. So, sort of going through all of this, and there's just so much in there. And I actually gave a talk on this matter, and I'm compiling it in a presentation that will hopefully have accessible for everyone online in the coming months through a research grant, which would really be great for both practitioners and for individual patients to kind of go through, what is my risk? How can I understand my risk? And what can I do about it?
Well, thank you so much. I think we all learned a lot, and this does raise awareness on this really important topic and the importance of prevention and screening. So thanks for spending this time with us today. I know that I greatly appreciate it, and the audience will as well. So thank you, Dr. Poonja.
Absolutely. Thank you, Lindsay.